Thank you, Rinwa. That was a very kind introduction and maybe a little inflated. But it's a pleasure for me to be here with you this morning to talk about stewardship and what's happening on the national scene that's really driving the new regulatory expectations and a lot of the discussions we're having right now about improving antimicrobial use in long-term care. And I think you are really fortunate to have resources in your midst, like Dr. Dimyati and her team, as well as the folks at the State Health Department in Albany, because they are trying to provide you with the resources and knowledge you'll need as you're implementing these kinds of medication improvement initiatives in your facilities. Just curious, how many of you work directly in nursing homes full-time? Terrific. And how many of you have been in this arena for more than 10 years? Great. Okay. So this is a very experienced group, and so hopefully you've sort of seen the changes coming. Sorry, I'll make sure I'm doing this correctly. In the population and in the in this setting, because I believe over the last 10 to 15 years we've seen a real shift in the kind of resident population being cared for in nursing homes today. And that really has moved from the traditional long-stay custodial care that most people still think about when you talk about long-term care in nursing homes to a very complex, medically complex population that looks far more like the folks that you see in a hospital than what we would expect. And so over the next few minutes, we're just going to talk about some of the new regulatory expectations and why we're seeing these new changes in the infection prevention and stewardship program expectations in nursing homes. We'll talk about the core elements for antibiotic stewardship in nursing homes, and hopefully you've seen these documents, but if not, this will be a nice overview to get you familiar with those, that framework of stewardship for nursing homes. And then as we go, hopefully stimulate some ideas for how you as consultant pharmacists can become leaders in this effort for your facilities. So as I was saying, those of you who've been practicing in long-term care for a while have probably seen this shift in the population. And a lot of that has been driven by the post-acute care admissions coming directly from hospitals and going into nursing homes, not for long-term or permanent residents, but really for the short stay, rehab, and skilled care. And those individuals really do look like and bring a lot of the same risk factors that we would see in a hospital population. They're often post-surgical patients with wounds that need management. There are individuals with indwelling medical devices that are also risk factors for the acquisition and transmission of antibiotic-resistant organisms, and we're seeing a lot of antibiotic use in this group. In fact, when you look at the proportion of antibiotics given in the short stay versus the long stay population, you see much higher rates among the short stay population. And these infographics just illustrate how the case mix and the complexity of resident care keeps steadily increasing over the past few years. So how does this individual or this population kind of look? It's useful sometimes to look at a story. So this is a story that actually came out of a chart audit done by the Office of the Inspector General as part of their report on harms and adverse events. So this is an actual record and experience that they found documented. It was a 99-year-old gentleman who had a urinary catheter placed in the hospital because of obstructive uropathy. And at the time of his discharge to a skilled nursing facility, they wanted to have him follow up with urology in terms of managing the device in about 2 weeks. And in the chart, at about that 2-week mark, in fact, they noted that the resident was started on an antimicrobial, despite the fact that in the documentation he was afebrile. There were no localizing signs or symptoms captured, but there was a urine culture submitted. And so because of the inadequate or missing information. There wasn't a clear explanation of why it was submitted. But how many of you are surprised to hear that that urine culture showed a lot of bacteria and white cells? Anybody surprised? This is an older gentleman with an indwelling device. So we kind of expect that, right? That's what happens when you have these devices in place. It automatically allows for organism to enter the bladder, and generally the device itself can be irritative enough to cause a white cell local reaction. So the pyuria and the positive bacteria by itself, to me, doesn't help us differentiate whether this is a symptomatic UTI or if this is just the presence of a device in an older person who is very high risk for asymptomatic bacteriuria. And yet, as a response to that positive culture, he was initiated on Augmentin plus Rocephin. Then a couple of days later, the Rocephin was stopped, perhaps when the susceptibilities came back, and then a week later, that Augmentin was changed to ertapenem as a second culture was available. What do you think happened there? Did the second culture grow something? Probably. Was it now resistant to Augmentin? Probably, yeah. And so they needed to broaden the spectrum of the antimicrobial to cover this new bug. Yet, again, no documentation that there are clinical signs and symptoms to justify perhaps this pretty broad spectrum therapy now. So what happened? He ended up in the hospital a few days later because they didn't know what to do with their antibiotic management. It had gotten beyond them. And my question to you is, what do you think are the issues that led to a hospital transfer? What are you seeing here that concerns you, if anything? So poor documentation, I would absolutely agree with that. We don't have any understanding of the rationale for the decisions here. We just see the response to testing, primarily. Anything else?
Who ordered the urine culture?
So we wonder about who ordered the test that sent them down this path, and why did they do that? And if you remember back at the beginning, they were actually, it was recommended that he go follow up in urology, maybe get that device out. And so we have a device that's persisted, created a risk for bacteriuria, and now sent this person down a path that ended up landing them in the hospital. So in terms of the OIG report, that scenario was considered adverse event because the level of change in that individual's clinical course was substantial, right? He ended up back in a hospital as a result of this, this series of decisions and events. And what they were looking for were these harms that were occurring pretty early in somebody's SNF stay, so within the first month, basically. And hopefully you've heard of this report. Has anybody seen it or looked at it? So I would say it's valuable to understand the kinds of harms that they identified. And when they define adverse event, they really mean a harm that was significant enough that the trajectory of the resident changed. So going back to the hospital is an example of that, or functional decline. To contrast it with a temporary harm, such as somebody was noted to have a very low blood glucose, and then they got juice, or they got some D50, and now they're immediately reversed that problem. So that was temporary harm. If you had to guess, as clinicians and as consultant pharmacists, what might have been the number one cause of harm identified in this report? Anybody want to hazard a guess? You all are the leaders in this area. That's a hint. Medication. Yeah, so about 40% of the harms, the number one cause of adverse events in this group were medication-related adverse events. They had another bucket of harms they called resident care harms, and it was about a comparable number. They were both, medications was 37%, resident care harms was 37%, and that bucket, though, consisted of a whole bunch of different types of harms. So it was falls, new pressure ulcers, dehydration. It tended to be issues that came from a lack of either recognizing that somebody had an issue happening, or a lack of testing, or maybe lack of safety in terms of falls and things like that. But it took lumping a whole bunch of things together to get to that 37%. In infections accounted for the other 26%. So in my mind, you have medications, infections, number 2, and then everything else related to resident care, number 3. And I just wanted to show you a little bit of data about the infections as a cause of harm and adverse events. You can see that there were more serious harms from infections than sort of temporary reversible. And a lot of that had to do with the hospitalizations. Look how many of these infection-related harms drove people back into the hospital. And you know that readmissions are a huge area of focus right now in terms of quality improvement in nursing homes. And there's a value-based purchasing incentive coming pretty soon in the next 2 years that will particularly focus long-term care and nursing homes on this issue of rehospitalization and readmission. And the other thing to point out is look how many of these serious harms were thought to be preventable, almost 60%. So when you think about resource allocation and focusing your efforts, it seems to me like this is a very ripe opportunity for improvement, and that you could do a lot of good if you're able to address some of these issues. So let's look at the types of infections that cause those adverse events. And I don't think people who are familiar with this population are surprised to see that lower respiratory tract and pneumonia are one of the leading causes of harms in this population. But what I do want us to think about is the preventability issue, because again, when you're talking about limited resources and where do you focus your efforts, you have to think about where can I do the most good. And for me, when I talk about infection prevention programs, I really say try to key and prioritize on those things that you can actually change. And this is where I find urinary tract infection and C. difficile infection may provide some better opportunities for us to make impact when it comes to prevention. And so what this report did for me, and hopefully did for providers who became aware of it and thought through some of these issues, is what are the themes that identify for us the opportunities? I think the point about documentation is an important piece, because it gets at our recognition that there's a problem, and our communication not only of what the problem is, but what our response and reaction to that problem should be. So if we have ways to standardize our approach to assessing residents when we have a concern, and make sure that we are defining these events and monitoring for them, that might get us a long way down the road. Better documentation of our response to those concerns. And in that case that we looked at really does illustrate this point pretty well. And then there's an accountability piece. There's onus being placed on us as providers to implement changes. It's not enough to just count events anymore and to have a list of them. We have to actually demonstrate that we're reacting and making some positive changes in our practice so that we can drive these events, these harmful and adverse events, down. And this is where I feel you all as educators, as resources, especially when it comes to medication management and medication safety, are such critical assets to our providers. So I said, urinary tract infections and C. difficile infections are, to me, two of those areas where we have a lot of opportunity to improve and to reduce harm, and we may have a lot of impact. When I think about this triad, there's something for me that connects these two events. What do you think it might be? Sorry? Well, it could be education, medication, antibiotics. Yes, exactly right. So why stewardship, and why are we talking about it now? Because we know that there are these infection-related harms that are preventable, and what we see is when we explore the opportunity to improve our management of urinary tract infections and to reduce the problem of C. difficile, we immediately come to this issue of asymptomatic bacteriuria and the way we use antibiotics in this population. So all of us end up in the same sort of conclusion, and this is the way we need to focus. So in addition to what we've seen around infection prevention in the nursing home population, there's also been a parallel message around reducing antibiotic resistance and the role of antibiotic use and misuse in the problem of antibiotic resistance. So about 3 years ago now, I can't believe it's 3 years, but the CDC put out the antimicrobial threat report, and it basically was identifying these high urgent pathogens that we need to think about in healthcare in order to reduce the harms, the infections, and the deaths related to resistant organisms. Why do we focus on resistance so much? What is the concern? They're harder to treat, exactly right. They're often, it's more costly to treat these infections. There are fewer options for treating these infections. And for those of you who are, thinking about the cost in terms of drug expenditures, you see this as you have to move from Augmentin to ertapenem. That's a pretty big differential in cost, right? And the broader and broader spectrum agents, and certainly the newer agents, are going to be more expensive. There's also a real patient safety issue here, because the types of infections and the severity of infections from these antibiotic-related events are much more severe. So in addition to being more expensive, we have worse outcomes for our patients when we deal with resistance. About a year after that threat report, the CDC put out a report looking at antibiotic use in hospitals. And they saw that in a single day prevalence survey looking at antibiotic use, 50% of hospitalized patients were receiving antimicrobials, like 1 out of every 2 people, which is pretty high, right, when you think about it, and you think about just how many people are in hospitals every day in this country. And there in this report, they also identified some real opportunities for improvement, anywhere from 25 to about 35% of the use seemed like there were ways to optimize or improve, if not totally halt the use where there was a lack of symptoms. And like the case we looked at, there were therapies being driven by culture results and not necessarily by assessing the patient's needs. And it really started to signal for healthcare that we need to have a better focus on this problem. And it's not just a unique issue for hospitals. And that really came out later in 2014 in the fall when the White House basically put out an executive order saying we have to combat antimicrobial resistance in this country, and we need to look across all healthcare settings, not just hospitals, and recognize that there's opportunities in long-term care, outpatient clinics, as well as hospitals to do a better job. And this is a huge piece of our strategy to reduce resistance and the risk that we are going to end up in a place where we don't have drugs available to treat people. It would be going back to the days before penicillin, where people were dying of infections because there were no options for therapy. And I think it was a really major step that very much up front in the White House call to action and the subsequent strategic plan that came out to combat resistance, that when people talked about stewardship, they included nursing homes and long-term care settings. I think often we see these quality improvement initiatives and large agendas start with acute care hospitals and get stuck there for a while before we start to recognize that there are other places where healthcare is delivered. And here we see upfront long-term care and outpatients included as settings that we need to focus on when it relates to stewardship. So I wanted to show you some data about how antibiotics are used in nursing homes so we can kind of put a context around why I think it's so important that we're asked to look at this now. There's a huge population of individuals coming in to receive care in nursing homes every year. When you account for the post-acute population that's continually transitioning in and out, you see several million people above the typical capacity of what 1.7 million beds that we think of when we think of nursing homes. So this group, as we talked about already, is coming in with a lot of complexity, a lot more antibiotic exposure even before they hit our doors. and that is going to increase the likelihood of antibiotic-related complications like resistance, like C. difficile. But if you look at just the way we as nursing homes use antimicrobials, we also see quite a bit of use. Now, in a single day, who wants to guess in a single day the proportion of residents receiving an antibiotic? Do you think it's as high as 50%? No, it's not. Anybody want to throw in a number? It's too early in the morning for this, isn't it? Sorry? 20? So it's about 10 to 15%. So 20 is a great guess, yeah. So of course that varies by facility, but on average, that's about the number we see on a single day. And when you compare it to 50%, you think, well, that's not such a big deal. We're not using as much drug as our counterparts across the street. But here's the rub. When you follow a cohort of residents over time, that's when you start to see the very high exposure to these classes of drugs. So over the course of a year, there are numbers as high as 50 to 75% of residents that will receive one or more systemic courses of antibiotics in a year. That's the problem I see, and that's our opportunity, is to look at that kind of exposure. And like what was seen in the hospitals, we have a wide opportunity to do a little bit better with these drugs. And this range is quite large, and people ask me, why is that? And I think the real issue here is all the studies that look at appropriateness define appropriateness slightly different. So a lot of your estimate of appropriate versus inappropriate has to do with what you're looking for. And if you think about how we can use medications, there's the indication, should this person get it or not? But there's also, did we dose it appropriately? Did we have the follow-up to make sure there weren't adverse events related to that drug? Did we have the documentation that justified? So depending on how studies try to define this, that's why you see this very broad range. I do think as a community, you all could do a lot to help us inform the best standards for defining appropriateness based on the experience that we have. This is some data that's pretty recent from Canada, and because of the Canadian healthcare system and the way medications and healthcare is paid for by the national health system, they have a lot of really impressive data on utilization of services. So they were able to look at antibiotic use patterns for a cohort of long-term care residents that touched nursing homes in Ontario over the course of the year. And as we were talking about, what they saw was 75% of the residents, translating to about 50,000 individuals, received one or more courses of antibiotics in that year. So those are the kinds of numbers we talk about when we see a group followed over time. So this was really focused on antibiotics as opposed to antivirals. That's a good question. They were able to look at the lengths of therapy as part of this analysis and found that about 45% of the antibiotic courses that were prescribed were fairly long. They exceeded what was the median duration of therapy, which is 7 days. And they looked at the factors that might be associated with somebody getting a shorter course versus what they called a prolonged course. And they modeled this, so they tried to adjust for things like the resident complexity, the number of residents under the care of a provider, the case mix of those residents, because often when you talk to people, they say, well, my residents are more sick, and that's why I need to use more drug, right? And that's something we hear. And yet, when this model of huge thousands of providers and thousands of residents, the only factor that fell out of the model as significant was the provider who wrote the prescription. The type of resident, their underlying comorbidities, presence of dementia, none of that made a difference between getting a shorter course and a longer course. I think that's important as we think about how we approach this problem in our facilities, to recognize that there may be a lot of variability in how providers and prescribers think about these drugs and the role that they have. And if you're not able to find those outliers, you may not be able to really rein in the antibiotic use in your building. How many of you are involved in the antipsychotic medication initiatives in your facilities? hopefully all of you, raise your hands. And how much did you notice that there were differences in individual providers and their thoughts about how these drugs should be used? Seeing a lot of nodding heads. Okay. There's no difference to me about our approach to this issue with antibiotics than there is with the approach to how you looked at antipsychotic medication use. In both situations, there are times when these drugs are appropriate, and there are times when they are not. And oftentimes, the clinical providers' behavior, their perceptions, their anecdotes, if you will, are what drive them to prescribe one way or the other. And until you unpack and uncover those differences in beliefs, it can be very hard to change their behavior. Is that true? Did you have to have some hard conversations with a couple of your medical directors or some of your colleagues who are prescribing? So I think you've already had a tremendous amount of experience in this area. And I don't want you to think about stewardship as something completely new, that you have to sort of start from the beginning, because you've already created a lot of platforms for approaching medication safety through the Antipsychotic Medication Reduction Initiative. You just now have to translate that to another class of drugs. Does that make sense? Okay, so this group tried to unpack a little bit more about the providers so they could understand where this association with use and prolonged use kind of came at the physician or NP or PA level. So they found that there were about 2,600 different physicians prescribing antibiotics contributing to this study. Interestingly, 20% of the providers were responsible for almost 80% of the utilization. Is that surprising to anyone? It's those outlier folks, right, that have just a different thought about what we should be doing with these drugs than maybe their peers. But again, until we have the capacity to find those individuals or to see that pattern of use, how do you rein it in? It's very hard. So I think for me, the takeaway is we have to look at prescribing practice by individual prescriber so that we can see the comparisons and to see whether we have some of these individuals who may be driving up our use more than others. They looked at the sort of long duration subset of providers, and again, they could not find any differences between the patients, the residents being cared for by these long duration prescribers than the rest of their peers in the cohort. And I think that's sort of beating the message enough, but that they're clearly something that we as clinicians bring to the table that we may or may not recognize about ourselves, but that contribute to the issue. The other reason why I think this is such a critical point for us to be talking about right now is that antibiotic use is not benign. And because we've had drugs that are relatively safe and tolerated fairly well, we have lulled ourselves into complacency about the harms and the risks from using these drugs. But there are a lot of side effects, and I'll tell you, the side effect profile and the drug interaction risks and adverse drug events in the older adult population from antibiotics is much higher in terms of risk than what we might think of in just the general adult, younger adult population. And there are some really key drug-drug interactions that, as nursing home providers, we need to be paying attention to. So this is a little bit of a read my mind, so I apologize for that. But what are some of the classes of drugs that you can think of that cause harm in the older adults? Sorry? Bactrim? Okay. And even think beyond antibiotics, other classes of drugs. Opioids, is that fair? And sets anticoagulants. So what is the risk of, or is there a risk with anticoagulant use and antibiotic use? Yes, what's that risk? There's an increased risk of bleeding, generally with warfarin, right? Because you basically are wiping out the gut flora that contributes to our vitamin K stores, and that's the effector place for Coumadin or for warfarin. So if we're not paying attention to something that simple, right, and saying, oh, Mrs. So-and-so is taking warfarin and now we're initiating a course of Augmentin, we need to check an INR in a few days to make sure that we haven't radically changed their level of blood thinning. That individual, if they fall, I mean, the harm that can happen, and we may be misattributing this to a misadventure with their warfarin, when in fact it is the interaction with an antimicrobial. So these are the kinds of serious harms that we see impacting the older adult population, and we may not be recognizing or attributing the harm correctly. Risk factor for C. difficile infection, hopefully you are very well aware that the number one risk for getting C. diff and getting infection from C. diff is antibiotic exposure. And it's really a cumulative problem. So it also similarly is a driver for acquiring and developing infections with antibiotic-resistant organisms. And I think you've seen this in your practice, where you watch a resident get course after course of drug and see that the profile of resistance gets worse and worse and worse. And that's clearly what happened in that case we were looking at this morning. So the Canadians did another study and basically demonstrated that when you look at the variation in antibiotic use overall in different facilities, and they had about 600 nursing homes where they were able to define the amount of antibiotic days per 1,000 resident days, so the rate of antibiotic consumption in days of therapy. There was a subset of nursing homes where the risk for having an antibiotic-related harm was substantially higher. And you can see the range in antibiotic use was quite broad, from 20 days per 1,000 resident days to as high as over 190 days per 1,000 resident days. And what they defined as high use, this group that ended up having 25% increased harm in all the residents, not just those who received, but there was a harm to those people in the building. The defining use that was considered high was over 62 days per 1,000 resident days. So if we're not able to capture that data and look at that data in a comparable way, we don't even know whether our facility and our residents are at risk or not. But I think these are setting some standards for how we ought to be looking at this and measuring the problem. There are a lot of issues. I don't want to be dismissive of the challenges that you face when it comes to antibiotic use and understanding use in this environment. We have a lot of off-site prescribers, right? They're getting information by the phone, and they're not the ones in the building necessarily doing those assessments. So if there's a problem with information flow, or if there's an uncertainty in the mind of the provider about how likely frontline staff are going to go back and reassess or identify a problem, their threshold for initiating therapy is going to be much lower. So we have to look at how we are assessing and communicating our plan of action and our decisions, given that people making these prescribing decisions may not be there in the building. And one study looking at antibiotic starts in nursing homes found, 2/3 of the prescriptions were done by someone off-site. The documentation issue, again, when antibiotics are initiated, and the same study found that about 40% of the time you couldn't figure out why the antibiotic was started when you went back and retrospectively reviewed the chart. And for those of you who go and do chart review, I'm sure this is not news. But clearly this is a need for us to change. And you all, as educators, can make that happen and help facilities do a better job here. There are also issues with getting access to and timely diagnostic testing and the quality of diagnostic testing that you can follow up and make additional changes or decisions about whether to continue therapy. And we know and hear frequently from providers that it's not us. We don't want to start the antibiotics, but the families make us do it. That's really our fault, right? Because we taught families along the way that minor changes in behavior, that's a UTI until proven otherwise in grandma or your loved one. And we have to now redefine that conversation with our families and our residents. And so, yes, it takes more time, but this is true no matter what arena you practice in. If you're going to try to make sure patients are understanding and satisfied with the decisions, you have to take the time to teach them why. And demonstrate that you aren't dismissing their concerns. You agree that something's different today, but you don't necessarily think an antibiotic is the right answer. You need to do some additional assessment, following, monitoring, and mark that change. So we have some work to do in order to bring everybody on board with this effort. I want to just talk about briefly the regulatory issues. Right now, this is the existing interpretive guidance and the federal tags related to nursing home care. FTAG 441 is the infection control tag, and there is language right now in that tag talking about doing antibiotic review as part of your strategy for reducing resistance and the spread of resistant organisms. In addition, I think there are several tags related to medication use, and you all are probably intimately aware with these, that also support right now, today, our efforts to promote stewardship in this setting, because we are obligated to make sure that the use of medications are safe, that we are putting practices in place to reduce adverse events and to identify adverse events when they happen. And we know the data say antibiotics as a class are a very high risk category of medications for adverse events in this population. So you all have a critical role there. But there are some new proposed rules, and Rinla sort of alluded to them. Let me just show you some of the prevention and stewardship regulations that are incorporated in the new rules. So these are the infection prevention regs that talk about doing a risk assessment on an annual basis to look at your resident population and make sure that the resources and the actions of your program are meeting the needs of this population. This is something that's become standard of practice for many years in hospitals, the annual risk assessment as a mechanism for prioritizing your prevention efforts for your infection prevention programs, and now nursing homes are going to be asked to adopt that same strategic approach to resource allocation. Reviewing and updating your program policies, at least on an annual basis. I think this is, I'm going with an annual basis, although that level of detail is not in the reg yet, but it'll be interesting to see how they set a time frame. If you're doing an annual risk assessment, though, it would make sense to me that you would look at your policies at the same time and say, do my policies and programs still meet those needs for the residents as they're changing? Designating an infection prevention and control officer, which I think is critically important. There isn't a specific amount of time that is proposed in the reg, and I don't know if there will be something that specific. But they do say this individual who is tasked with overseeing infection prevention control needs training, which is a major improvement, because right now we find that the vast majority of nurses and providers that are doing infection prevention in these facilities don't have any dedicated specific infection prevention training. And this is not simple stuff. This is complex. There are a lot of pieces to a program, and if you don't have any time to really understand what it means to do surveillance and what it means to track resistance and what it means to implement bedside practice change, it's a daunting and overwhelming task. And finally, they're integrating infection prevention under the umbrella of quality assurance and performance improvement, or QAPI. And I always point to infection prevention as a perfect example of QAPI, because you've got your surveillance, you identify problems, and then you drive changes at the bedside based on the opportunities to reduce those events. So that is exactly what using data for action is all about. In terms of stewardship, a lot of the stewardship language is integrated within the infection prevention regs, but specifically there's also language within the pharmacy regs that are related to antibiotic use. So there's now the medication review will also include antibiotics. So they broadened that, and they are making it part of the monthly medication review process. In addition, when new admissions or readmissions come back to the facility, looking again at the list and looking for antibiotic use and the appropriateness there. There is some language about having protocols to govern and improve antibiotic use. There's not a lot of detail yet on what that might be, as well as monitoring of antibiotic use, measuring use, which we've talked about the importance and the value of that in a couple of different ways. And I know there's a whole session next to think about that, so hopefully you'll get some additional ideas about how to do that monitoring, and again, integrating it into QAPI. So what does stewardship look like? I think this is what a lot of providers right now are asking, and I hope, and your feedback would be very valuable to me, that this framework that we put out last fall might help us to answer some of that. And so the CDC had put out at the same time in 2014 that the report about hospital antibiotic use was highlighted. They put out the core elements of antibiotic stewardship for hospitals, and they laid out 7 foundational pieces that every hospital program needs to have in place. And those are listed here. So leadership commitment, accountability, expertise, some action, some measurement or tracking, reporting, which is really giving feedback to people so that they understand what these outcomes and processes are looking like, how well they're doing at the bedside, or in this case, when they are initiating therapy, how well they're following those protocols about appropriate use, and education. Now, if you take away the word antibiotic and just put quality improvement, I think you would agree, right, that these are the same 7 elements that you need for any quality improvement initiative, and it could be your antipsychotic medication reduction initiative as well, right? You need leadership to be on board, you need people to be champions and accountable for the work, you need some kind of expertise, and it may be in-house, or it may be that you have to get outside supports and bring some expertise to help you. There has to be some change in your policy or your practices. There has to be a way to measure the impact of that change. You need to feed that back to people so they know that they're making good decisions or that you're having the impact you want. And you have to educate people. So it's really fill in the blank. Whatever quality improvement activity you want to take, this is probably what you need to have in place to be successful. And what we did with the core elements for nursing homes was try to look at these same 7 elements and how do we apply them in this setting. I don't know how easy it is to read these, and I know that the slides will be available to you if they're not already, but just at a high level leadership commitment, you know, it's who is your corporate leadership, who's the administrative leadership. Do they agree that stewardship is an important piece of resident safety for the building? Over and over again, I hear stories from clinical directors of nursing or medical directors saying, you know, I want to make change, but there's not a lot of support coming from the people above me. And if I run into a problem with a provider who's just not willing to get on board, there's no leverage, there's nothing I can do to change that because I don't have anybody above saying, yes, we are going to hold you accountable for your practice. And you may have seen this also when you were working on and reducing antipsychotic medications. If the corporate or administrative leaders didn't really buy into what you were trying to accomplish, you may have run into hurdles and roadblocks that made it hard to succeed. So you have to think about who are the leaders and where are they in this issue. Accountability. Accountability in this particular issue, I think, is not an individual person, but it's really a team of people who have to be working together. I think you need a physician lead. It could be the medical director, or it could be another attending that is a real champion and has influence over their peers. There needs to be nursing leadership and pharmacy leadership because every person at the table has a very important role in shifting the mindset and the attitudes and practices. And a lot of times, because providers are not on site, who's really starting the decision-making process for starting an antibiotic? Frontline nurses might be, right? They may notice that there's a change, and they may need to notify somebody, but what do they bring at the time they communicate that concern? What is the information that they're asked for? What is the information that they have gathered? And if there is a disconnect, then the provider may be acting and making decisions on incomplete information. And it's often the way we start the conversation that drives their decision. So, for example, Mrs. Jones had a positive urine culture come back today, and it's got greater than 100,000 E. coli, and it's susceptible to ciprofloxacin. If I start the conversation that way, I'm already leading the provider down a path, right? If I say instead, so Mrs. Jones had a urine culture come back today. It was sent 2 days ago when she wasn't acting like herself, but now her appetite is fine. She's been active and participating in physical therapy. And it seems that whatever issue was happening a couple of days ago when this was sent has resolved itself. So although there's greater than 100,000 E. coli, I'm not certain that we need to act on it right now. There's two different, it's the same information. It's presented in 2 different ways. And I think if you don't have some strong nursing leadership that helps support that kind of messaging, or at least gathering those levels of information to provide, it really upfront disadvantages the prescriber in terms of how they're going to handle this decision. you all, as consultant pharmacists, are critical partners. And I'm going to stop on this slide for a little bit because I feel like you have so many places along the path here where you have opportunity for influence and to provide your providers and your facilities with critical information to make change happen. So you all are part of that triad, you know, working in partnership with the clinical team to say, how do we educate our staff to understand these drugs, to understand the risks of these drugs, as well as, you know, the opportunities for monitoring the use of these drugs. Because a lot of these frontline staff may not remember, and they may not be as familiar with the medications that they're using or suggesting as you are. Looking at antibiotic prescriptions as part of your monthly review, and there are some different ways that you can do this. I think if you work with your clinical team to develop some protocols for managing infections in your building, then you have a pathway to say, did they follow the protocol? Yes or no? If we're all sort of making it up as we go and we don't, then we have no guide. And I think more and more we're recognizing that providers want to have some help making some treatment selection decisions, and we want to use our data to help best inform. So for example, if you know that 50% of the time E. coli in your building are resistant to ciprofloxacin, is that still the best first-line drug to empirically starve somebody who has a UTI? That's flip a coin and it might work. And I don't think that's necessarily the best choice. So, but if nobody's aware of that resistance and nobody's thinking about how to incorporate that information into their decision-making pathways, then everyone's left sort of making decisions in the dark. So working with your laboratory, to see how the antibiotic use in your building maps to the antibiotic resistance in your building, that's a very powerful piece of information to guide changes. And helping providers and facilities see their use in a meaningful way. So we talked about days of therapy. We talked about provider-specific prescribing patterns. I mean, these are some very straightforward pieces of information that make the data actionable. There's something I can now see. It might be that you look at different classes of drugs and ask, are we using one class really all the time? And if we can tie it back to our resistance question and say, well, is that the most effective drug? That gets us a lot of powerful information to make the case that change may need to happen. So you all are at the hub of a lot of information and could be a huge, huge driver of identifying those opportunities for change. There are other groups that I think we have to engage in this, and the Infection Prevention Control Officer, I've already mentioned what they can bring to the table, including how they monitor infections and antibiotic use as part of their surveillance, their awareness of resistance patterns, and the consultant laboratory is another group that has key information to share. How many of you have seen an antibiogram for your facility? A couple. That's fabulous. Does everybody know what an antibiogram is? Maybe that's a fair, yeah. So it's just in case, you know, it's a summary that's done by the laboratory of all of the organisms cultured for a facility in a given time frame. Usually it's a year. Sometimes it's every 2 years because the volume of cultures is a factor when you're interpreting these summaries. And they look basically at, of all the E. coli that were cultured from the residents in this nursing home, what proportion was susceptible to a series of agents that would be appropriate for use in therapy. So to Bactrim, to ciprofloxacin, to Augmentin. And it allows you to see in a snapshot the effectiveness of some of the common drugs that are used for these different organisms. And it gives you a feel for how likely is it for this drug that I'm choosing to work or not work for this population. So if you don't have access to an antibiogram, that is a conversation to have with your clinical team and to say, can we reach to the lab and talk to them about getting this resource? It's going to be tremendous in terms of improving our use. The state and local health departments and colleagues like Dr. Dimyati and their team here in Rochester, well, not here in Rochester, but there in Rochester, and the outreach that they're doing to bring groups of facilities together and work in a collaborative, I think that's an incredibly powerful way to share resources, to share learning experiences. Have anybody participated in their building in a collaborative around anything? It could be antipsychotic medication reduction. It could be reducing pressure ulcers. It could be, some of you are nodding. So was it useful? Did it help to get together and talk to other people? Yeah. And you build a network, too. So you start to build a network of colleagues that you can call and say, I'm having a real problem with this today. Did you face this? And how did you overcome it? It gives you ideas because we're all trying to accomplish the same thing. We don't need to reinvent the wheel as individuals. And you get involved in a group like this, you get a lot of bang for your buck. Bringing drug expertise. In this case, you're talking about infection management and antibiotic use, and some of you may be very, very comfortable with how these drugs interact and have side effect profiles and how we have to measure, monitor for safety, but some of you may not. And so again, if you have access to people who think about antibiotics and their safety profile and how we measure them all the time, these become valuable assets to make a part of your portfolio of tools. Nursing homes, it's a little harder, right? You don't have ID docs running around nursing homes. You don't. And you're lucky if you have an in-house pharmacist who can provide some of this support, but you may not. So you have to be creative sometimes in thinking about how to bring drug expertise to the table. But partnering, again, with colleagues from the hospital who are interested in working with you. And how many of you have facilities that are becoming more and more tightly affiliated with the hospital system? Anybody? A couple. I mean, they are motivated to help you. They have a real self-interest in not seeing those residents come back to them, right? They have a self-interest in not seeing C. difficile happen in your buildings. They have a self-interest in not seeing those complications and adverse events happening. And a lot of hospitals are building antibiotic stewardship programs already. And so they may have some expertise available that you could tap into. They may have pharmacists who are dedicated to doing antibiotic stewardship, and those colleagues of yours could be remarkable resources. You don't, again, have to reinvent the wheel. Say, how did you deal with this problem of measuring use? What did you use? Did you have a tool? Could I see it? Could you help me? And you can get a lot of traction from taking advantage of the partners right around the door from you and your community. We've talked about some of the kinds of actions that you can take. And I think one of the key messages for nursing home providers is you don't have to solve the whole world's problems in one shot. Take one issue based on what you've learned from looking at your data. Take one issue and try to improve it. So, for example, do you have a policy that expects that when an antibiotic is written, that there is a dose, a duration, an indication, and that's communicated to the pharmacy, and it's codified in some way? And a lot of facilities say, yes, of course, that's part of medication safety. And so every drug that we order has to have those things in place. But do all of you feel like you know the indications for drugs when they are started and antibiotics when they're started? No. So clearly there's a gap there between what they think they should be doing and what they're doing in practice. And if you could just show that to them, if you could just say, look, I've reviewed 20 antibiotics over the last few months, and only 5 of them had an indication captured at the time it was ordered. Or maybe only 10 of them had an end date specified at the time of the order. These are very basic best practices around prescribing that we can prove. We can change that. And that might be all you need to do to get started, is that one very simple thing of auditing some use and finding an opportunity. So there are a lot of examples, and in our core elements documents we have a whole appendix of fun things to look at and different examples of initiatives and actions to improve practices. But don't get overwhelmed by that. Just pick one. Just pick one thing and start there. Same with monitoring. I think tracking is something that we are doing, but we are not doing in a way that it makes it useful. So you look at surveillance logs, for example, in nursing homes, and they've got a lot of information written on a logbook. But the question I always ask them is, what do you do with that data? How do you use that? How does that inform your infection prevention education for the month or for the year? How are you translating that information? And that can be hard sometimes because of the way we capture things. It's hard to interpret a line list. You have to be able to put some quantification behind it. You have to have some standard, like a rate, to allow you to compare from month to month when the denominators are changing and when the population is changing. Otherwise, you're not really sure if the number's going up and it's meaningful, or if it just meant you had more residents in the building at the time. So these are some very basic issues around tracking and measuring that if we're not comfortable with, if we don't have the right skill set to deal with, then we can't even tackle them. But again, some examples of ways that we can look at the process of prescribing. We can look at antibiotic consumption or antibiotic use, and also some clinical outcomes that are meaningful. So if C. difficile is a major problem in your building, that would be a logical outcome to track, to say, as we work on antibiotic stewardship, are we seeing that our C. difficile infection rate is going down? So you want to have some meaningful clinical outcome to justify and drive and help people continue to stay on board and sustain their efforts. Otherwise, we get distracted by the next QI initiative and we lose sight of it. And again, there's a whole appendix of ideas and examples and more detail about how you can measure. And again, you're going to get some of that this morning, so I won't go into it. But I think it's exciting that you have a whole day to just talk about this issue and think about ways that you can do this in your own buildings. And then reporting is really about providing feedback. If you ask me as a provider to change my practice, and I don't see the value there, or I don't even identify myself as a problem for you, then how likely is it that I'm going to come on board and do what you're asking me to do? It's far more powerful if you can come and say, Dr. Stone, I want to show you where your antibiotic use is relative to everyone else in the building. Now I'm a little bit stressed. Now I'm thinking to myself, I don't want to be that person over here, right? I feel comfortable with that. And I may be a little bit more amenable to your suggestions. I may be a little bit more open, if you will, to ways that I can rein back. But until you prove it to me, and I think physicians are among the most unwieldy group to really get, we're not self-actualized particularly well. So if we're not seeing the opportunity and seeing that our role in the opportunity to improve, then we may be obstacles for you. And so again, the data is powerful. It's hard to argue with data. Even if you don't like it, it's hard to argue with it. And education. Education is the last element, but I actually think it probably is one of the first elements. Because when you talk about getting people on board with something new, you have to tell them why. You have to give them the knowledge that helps them see the value and the benefit of making those changes. So, and we can't just restrict our education to the doctors or the NPs and the PAs. We have to think about the role of our frontline staff. We have to think about the role of our families. And their voice has to be addressed, and their needs have to be met when you talk about a big shift in the paradigm. And I think, especially with urinary tract infection management, this is a major change in the messaging that we've been conveying to families for many, many years, and to providers. There are a lot of clinicians out there who don't realize that in an older adult or an individual with a urinary device, the urine analysis is not a useful test, right? The positive test in a urine analysis does not differentiate infection. And so that's a pretty basic concept, and one that we've known about for many, many years, and yet we still haven't seen that incorporated into our clinical practice. It doesn't seem to translate to better behavior when it comes to interpreting these tests. So we have a lot to do. It's not going to change overnight, but I think that, again, you all are in the choir of influence to help bring some of this information back. So I just want to show you a couple of websites that hopefully, if you're not already aware of them, you'll go and look at, because there are a lot of examples out there of great work that's already been done, and papers and guidelines and talks. I want to show you a couple of papers that are highlighted on that website for clinicians that could help you create some algorithms for managing infections. And granted, these are getting a little old now, and there are some efforts underway to update, just like there was an effort a couple of years ago to update the surveillance criteria. There are efforts to update the minimum criteria as well. But they're probably not going to be huge changes, and I think if you start somewhere, you start with something, you're going to be farther down the road than a lot of colleagues right now. there are some resources on our website directed at families, and they could become a starting place for our conversation. How many of you have resident family councils in your buildings? Okay. Have you ever gone and done a presentation at a resident family council? At least one brave soul has gone. I would encourage you, if this is something that you choose to take on, I would really encourage you to make the time or get the permission. I know it can be hard. Time is precious for you. But to try to go and have that conversation with some of the family, the influential folks in the building, because you build some momentum that way. It's a grassroots kind of approach, I think. And these tools might be a way to start those discussions. There are also other educational materials for consumers out there. Hopefully you're aware of the Choosing Wisely campaign, but if you're not, I would encourage you to go to this website and look not just for the antibiotic stewardship information, but there's a lot about other issues related to patient safety. And both the American Geriatric Society and the American Medical Directors, or AMDA, I guess they've changed their name, right? AMDA, the Society for Post-Acute and Long-Term Care Medicine, they both have statements in the Choosing Wisely campaign about clinical care approaches and controversial topics to talk with families about in the older adults. And if you really just have no idea where to start, maybe this could be a starting place. This is a 2-page checklist that basically summarizes the core elements that we just talked about and could allow you to look at what are some of the current practices happening in my building. And it could be a really nice tool to take and sit down with your directors of nursing, your laboratory, and your medical director and say, let's just look at this together and see if we think some of these things are already in place. You might be surprised. There may already be some nice policies and some nice practices that are part of stewardship. You just don't call it that. And so this could be a way to capture that information and get you started. So to sort of summarize this, this is a national issue, not just in nursing homes, but across all of healthcare. And we're seeing some expectations coming in the near future for driving action in long-term care around this issue of resistance and improving our use of antibiotics. And you all really, again, are critical partners in making this happen. And it's so exciting to see so many folks here in the room and to know that, here in New York, you're already bringing a statewide collaborative together to bring all of you into the room and talk about this issue. And so I really commend Brandy and Dr. Dimyati for your efforts to convene this discussion, and hopefully you'll find that the whole day is incredibly valuable at getting you started if you haven't been sure exactly where to go. And it's not a new thing. It is really just part of the portfolio of medication safety work that you already do, and you already have those relationships in place because of some of the work recently you've done around antipsychotic medication use. And the same principles and the takeaway messages you learned from that effort, just roll them right into this one, and I think you'll already be way down the road. So I hope that this resonates and that this is something that you see as feasible and practical. It'll be very interesting to hear your thoughts as the day goes on. But thank you so much for inviting me to be a part of this, and good luck.
So I think we're going to leave the questions for before lunch.
Perfect.
We're running 10 minutes behind.
Okay.
So while while we're getting set up,